So coming to the case, long case presentation. So this is a 17-year-old male, so resident of Bhopal, who is a student studying intermediate. So he has presented with chief complaints of swelling over the neck, underarm, and the groin for the past since 2 months, and complaints of fever since 2 months. So coming to the history of present illness, patient was apparently normal 2 months back, and he has history of present illness was started as complaints of swelling over the neck and inguinal region 2 months back. Initially, he has noticed a swelling of around marble size, first in the right side of the neck and then in the right axilla, followed by swelling noted in the left groin. And the swelling has been gradually increased in size and attained to present size, and it has not associated with any pain or any ulceration or any discharge. And it has been associated with fever, which has started 2 months back, and the fever course was intermittent with the need of antipyretics. He used to take tablet paracetamol 650 mg once in every 2 days, and the fever was not associated with any rigors or chills. It is not but it is associated with drenching night sweat, requiring the changing of bedsheet during night times. And patient also has a history of weight loss. Weight loss noted was 4 kgs over the last 3 months, and there is an associated with loss of appetite was there. And the patient had a history of easy fatigability, but there is no history of bleeding gums or bleeding spots or gum bleeds. And there is no complaints of cough, breathlessness, or retrosternal chest pain. There is no complaints of facial puffiness or swelling, and there is no complaints of abdominal pain, vomitings, or loose stools. And there are no complaints of joint pains or any skin lesions, and no complaints of itching or generalized itching. And there's no complaints of any recurrent infections or recent history of any blood transfusions in the past. So coming to the past history, there are no history of any similar complaints in the past, no history of any pulmonary tuberculosis, and no other comorbidities. And patient had no history of any blood transfusion. And coming to the personal history, he's a vegetarian. Patient is a non-smoker, non-alcoholic. There is no history of any drug addictions, and there is no history of any high-risk sexual behavior. And coming to the family history was not significant, no history of tuberculosis or malignancies in the family. And coming to the treatment history, for the above mentioned complaints, patient has been evaluated outside at the local physician, and patient has undergone some minor surgical procedure from the neck swelling and referred to TMH for further management. So summarizing the history, a 17-year-old male, no comorbidities, no addiction, presented with complaints of painless generalized lymphadenopathy since 2 months, associated with fever, loss of appetite, loss of weight, which is over 4 kgs over 3 months, associated with drenching night sweats. So this is the summary of the history. So with this summary, the differential diagnosis in my mind was, first thing will be lymphoma, and second thing will be infections. In lymphoma, I would like to keep the non-Hodgkin's lymphoma first, and then Hodgkin's lymphoma, because of the pattern of the lymph node swelling. Patient has a swelling in the right side of the neck, and patient has a generalized lymphadenopathy, and patient has acute onset. And second thing was the pattern of lymph nodes was right side of neck swelling was there, right axilla swelling was there, and left inguinal swelling, which indicates the non-contiguous pattern of swelling. So that is the reason why I put non-Hodgkin's lymphoma in the first differential diagnosis among lymphoma. And second thing was because of the age, in this age group, though Hodgkin's lymphoma most commonly present with chronic and generalized localized lymphadenopathy, because of the age group, I would like to consider Hodgkin's lymphoma as the second differential diagnosis. And coming to the non-malignant causes, infections like tuberculosis and HIV are also my next differential diagnosis.
Any other differential?
Ma'am, in infections, yes, ma'am. In infections, we can consider EBV related infectious mononucleosis or toxoplasmosis. These are the infectious. And drug history, patient is not giving any drug history, but drug induced fever and lymphadenopathy can also we can consider. But here the patient doesn't have any history of drug intake, so that's why I didn't keep in the differential diagnosis. And autoimmune disorders like systemic lupus erythematosus and rheumatoid arthritis, but patient doesn't have any history of joint pains or rash or any other symptoms. So that's why I haven't considered. So these will be my differential diagnosis, ma'am. Lymphoma and infections, and in lymphoma first non-Hodgkin's and then Hodgkin's lymphoma.
Any possibility of
Ma'am, your voice is breaking, ma'am. Hello. Hello, ma'am, your voice is not audible. Hello, ma'am.
Ravi, I'm trying.
Ma'am, am I audible, ma'am?
Ravi,
Sir, yes, sir.
Network.
Yes, sir. In the non-Hodgkin's lymphoma.
yeah. So, madam has asked in the yeah.
Yes, sir. In the non-Hodgkin's lymphoma, my first differential diagnosis will be acute lymphoblastic lymphoma or leukemia, sir. And in the second will be diffuse large B-cell lymphoma. These will be my differentials in the NHL subgroup.
I'm not sure if I'm audible now. Is it better?
Yes, ma'am. You are audible, ma'am.
Okay. So, Ravi, when you said it's an acute onset swelling, it's not an acute onset swelling. You have something which is going on for 2 months. You can't call it as acute. Okay. So, he does have significant constitutional symptoms in terms of fever, weight loss. It started with lymphadenopathy, and then he started having these constitutional symptoms. Okay?
Yes, ma'am.
So, few things based on this. It's not really a very long history, as you rightly pointed out. And typically in Hodgkin's, we see relatively longer history. If somebody does not have that kind of a long history, doesn't mean that they cannot have Hodgkin's lymphoma. So it can very well be Hodgkin's. And as you rightly pointed out, it's non-Hodgkin's lymphoma. These are the two possibilities. I'm still not very convinced regarding your diagnosis of tuberculosis with this kind of generalized lymphadenopathy. Fever, weight loss, all fine, but I'm not really convinced whether tuberculosis will present with something like this in somebody who's who's immunocompetent. So I won't accept that diagnosis. Same way, infectious mononucleosis. So you don't have, the presentation what you see in infectious mononucleosis. Now, as you said that there is no skin rash, there's no joint pains.
Yes.
So, when you're talking in terms of inflammatory disorder, at this stage, you don't see SLE, you don't see, rheumatoid. What is more common is, stills is what is the presentation which you see. But again, the point against that is that you don't have joint pains, you don't have any skin rash.
Yes, ma'am.
So absolutely fine that we say that it is lymphoma, but at the same time, since it's 2 months history, there is very well a possibility of acute leukemia here, and you can have, acute lymphoblastic leukemia. You won't see, once you have these generalized lymphadenopathy, it's not that you can't have lymphoblastic lymphoma, but it's more like an ALL-like presentation, what you, get to see. So I would keep these differentials. And whenever you are trying to, put your symptomatology and chronology of symptoms, try and, keep both things in the mind when you are giving your differential diagnosis, rather than just, picking up few things that there is fever, there's lymphadenopathy, and that's why the TB will come in. But chronology is equally important. Then you are talking in terms of fatigue. So there is possibility whether it's constitutional symptom or it's, probably because of anemia. So you need to think in those terms that, we are thinking of anemia. We have somebody who's young, 16 years, has generalized lymphadenopathy, now constitutional symptoms. So there is still a possibility of acute leukemia because of these symptoms. So I would, analyze in this manner rather than just saying that it's, NHL for this reason and Hodgkin's for this reason. Okay.
Okay, ma'am. Yes, ma'am.
Anyone else? Okay, you can move on to examination if there is, yeah. Lingaraj just asked, is there any question from any residents? So if none, we can move on to the examination. I'm not
Okay.
sure whether you can share your slides. I don't see Akhil, I think. So
No.
you can continue presenting just like that. Yeah.
Okay. So coming to the general examination, so the patient performance status was 1 and his height was 160 centimeters, weight is 34 kgs and BMI is 13.3 kg per meter square and BSI is 1.22. Patient is conscious, coherent, cooperative. There is a pallor present, no icterus, and there was no engorged veins of the neck or upper chest wall. There is no facial edema, there is no upper extremity edema, and there is no pedal edema. And coming to the vitals, patient is vitally stable, afebrile, BPF of 110/70 in supine position, pulse rate of 80, regular, respiratory rate 22, and saturation was 99 on room air. And coming to the lymph node station examination, first coming to the neck on the right side, on inspection, there are multiple lymph nodes are noted on the right side of the neck, with the largest one noted in the level 2. It is of around 5 into 3 centimeter of ovoid shaped swelling with no visible pulsations or normal overlying skin. Coming to the palpation, there is no local rise of temperature and tenderness. 5 into 3 centimeters node palpable, extending vertically from 1 centimeters below the angle of mandible to 2 centimeters above clavicle, and horizontally it is extending 2 centimeters away from midline to posterior border of the sternocleidomastoid. And it is firm and rubbery in consistency. It is mobile, not fixed to the underlying structure like muscle or bone. And the overlying skin is also normal, and skin over the swelling was pinchable. Similarly, coming to the axillary, right axilla, there is a 2 into 2 centimeter mobile non-tender palpable lymph node is there. And similarly, on the left inguinal region, there is a 2 into 1 centimeter non-tender mobile palpable lymph node present. There are no epitrochlear or popliteal region lymph nodes. And coming to the systemic examination was normal. Per abdomen, there is no organomegaly, and testicular examination was normal. So these are the coming to the summarizing the history and examination findings. So a 17-year-old male, so no comorbidities, no addiction, history of generalized lymphadenopathy and fever for the past 2 months, with associated with B symptoms associated with drenching night sweats, weight loss. With an examination showing multiple lymphadenopathy in the right cervical region, right axilla, and the left inguinal, which is non-tender, mobile, and then firm in consistency. So considering this history and the examination findings, so I will try to rule out the remove the infectious cause of etiology, and then try to stick on to the lymphoma. That is, as I said earlier, the first differential diagnosis will be NHL, which includes acute lymphoblastic lymphoma or leukemia, and second one will be DLBCL, and third one will be Hodgkin's lymphoma. So these will be my differential diagnosis at the end of examination. So the points favoring lymphoma are firm, rubbery in consistency, mobile lymph nodes, which tends favor more towards the lymphoma, and there is no local rise of temperature or tenderness suggesting any infectious etiology. So that is the reason I have excluded the infections and then stick on to the lymphoma.
So Ravi, we are not thinking in terms of an acute suppurative lymphadenitis, correct?
Yes, ma'am.
Or for that matter, you're not thinking in terms of cold abscess that you are going to rule out based on the findings what you've presented on local examination of individual lymph node region. So we are not thinking in those lines that you said you ruled out infection. Correct?
Okay. Okay.
Unless you were thinking that it's acute suppurative lymphadenitis, or you are thinking in terms of that it is cold abscess due to TB, then you can look at all those signs that there is no sinus formation and there is no raised temperature, and skin is fine. So all that can't rule out infection. You're not talking about those infections. Am I right?
Yes, ma'am. Not ma'am.
So that cannot be the reason why you say that you ruled out infection. It's just because of the chronology, what we had discussed earlier. On that basis, infection is really low down. It's not on the top. And keep a difference between acute lymphoblastic leukemia and lymphoma. Yeah. So don't say that you have NHL and you're talking in terms of ALL. Know that, yeah, it does come under the B cell malignancies and WHO classification, but that's not how you present. I mean, when we are presenting, we are looking at whether it's leukemic or it's lymphoma presentation. Yeah. So let's not mix the two.
Okay, ma'am. Yes, ma'am.
Anybody else? Any other differential? Anything which we missed on examination? You mentioned skin examination, right?
Yes, ma'am.
Okay. Okay. Okay.
So next, coming to the workup. So first, I would like to do the investigation for the confirmation of the diagnosis. So right top, we are thinking acute leukemia is the first differential diagnosis, and then lymphoblastic lymphoma. So first, I want to do CBC, MDC, and with peripheral smear to rule out any abnormal cells or to look for any blast cells in the peripheral smear, in the MDC and peripheral smear to rule out leukemia. So, and then I just want to do viral markers, coagulation profile, followed by excision biopsy from the cervical lymph node.
Why you want to do coagulation profile, Ravi?
Before performing the procedure, just to rule out for bleeding axis.
So suppose his PT is prolonged, his
Yes,
APT is also prolonged, and his peripheral smear is normal, his platelets are normal. Would you consider doing biopsy or you would not do a biopsy?
No, we will do biopsy.
So I'm not sure how your coagulation profile is going to make a change here. You're not looking at biopsy from retroperitoneal nodal mass that you're worried about an internal bleeding that cannot be stopped by putting pressure. So I'm not really sure what's the value of coagulation profile here. If you have investigations, can you show those investigations?
So these are the investigations. So CBC HB is 8.6, platelet count was 2,62,000, total count was 18,000, and MDC was showing neutrophil of 80%, monocytes or 10%, and lymphocytes was 10%, and with no abnormal blast cells.
Okay. Would you want to have just hemoglobin platelet TLC? Your hemoglobin is low. Would you want to look at any other parameter?
Just want to look at MCV and then want to do any nutritional profile.
So not only just MCV, no?
MCV, yes, MCV, MCH, and MCH.
You want to look at all indices, including red cell distribution width. You want to look at all before you think of what is the type of anemia. You want to look at peripheral smear to characterize how the RBCs are looking. So you can't just say hemoglobin, TLC, and platelet. And when you're talking about these 80% neutrophils, you would want anything specific to be looked at there?
Look for any blast cells or
you would thinking in terms of acute lymphoblastic leukemia. We're not talking in terms of myeloid leukemia. So typically when you have this kind of a picture, you want to see whether there are any bands, whether there is any shift to left, anything which is, which indicates that why there is neutrophilic leukocytosis. You want to have a look at the peripheral smear to define that.
Okay.
Okay.
And like the patient has, just want to do excision biopsy from the cervical lymph node. So already patient has underwent biopsy outside, and those slides has been reviewed here. And coming to the microscopic description of the outside biopsy lymph node, and it was showing atypical lymphoid proliferation. So which was arranged in a nodular pattern and it has been separated by the thick fibrocollagenous bands. And it comprises large atypical pleomorphic multinucleated cell with prominent nucleoli in the background of lymphocytes and histiocytes. So based on this morphology, I just want to, because the cells has been arranged in the nodular pattern. So my differential diagnosis differential at this point of time, because it has been arranged in nodular, either it can be non-Hodgkin's lymphoma, multiple non-Hodgkin's lymphoma also present like this, or Hodgkin's lymphoma. In Hodgkin's lymphoma, predominantly nodular sclerosis will present in this manner. And in non-Hodgkin's lymphoma, based on the cell type, we can again divide what is the diagnosis. So if it is a large cell, the differential diagnosis will be preferably DLBCL, anaplastic large cell lymphoma, and then nodular sclerosis, Hodgkin's lymphoma. If it is a medium sized cell, then it will be mostly DLBCL and Burkitt lymphoma. So if it is a small cell, the differential diagnosis with this nodular pattern will be again small cell CLL, and these two will be the differential diagnosis. So in this case, there is an lymphoid proliferation with nodular pattern and comprising of large cells. And along with that, there is a pleomorphic multinucleated cell with prominent nucleoli was there, which significantly gives the impression of the Reed-Steinberg cell in the background of predominantly lymphocytes and histiocytes. So because of this, my differential diagnosis will be more towards the nodular sclerosis type of Hodgkin's lymphoma. And then coming to the histochemistry, immunohistochemistry, the cells are positive for CD30 and they are negative for CD15, CD20, PAX5, EBV, LMP1, ALK1, and OCT2. So based on this IHC, since the cells are positive for CD30, differentials will be again point more towards the nodular sclerosing type of Hodgkin's lymphoma.
Okay, so few suggestions, the way you have interpreted the histology and the way you have described that how you would look at when there are small cells, when there are large cells, and when there is nodular pattern. First and foremost, whenever you are having an axillary, whenever you're having a whole node biopsy, you need to first look at whether there is diffuse effacement or whether there is partial effacement. Yes. Whether there is, the nodular pattern, which basically means the germinal centers are preserved or not preserved. What about the follicles?
Yes, ma'am.
And whether there are predominantly neoplastic cells, which are monomorphic, or they are variable, or there are few abnormal cells, and there is a lot of reactive or the background cells which are present. Okay. In fact, when you say nodular pattern, and if you're moving towards Hodgkin's lymphoma, your differential diagnosis will go towards nodular lymphocyte predominant Hodgkin's lymphoma. Okay, so by seeing just nodular pattern, you can't say that it's we are talking in terms of nodular sclerosis. What is typical of nodular sclerosis is that you see a lot of banding.
Banding, that is what
that is the most predominant feature there, and you do see a small number of cells which are present which are neoplastic and which are large pleomorphic, and they may have multinucleated. They have more than one nuclei. So that is something which is more towards nodular sclerosis, not the presence of nodules. Okay. In fact, when you see nodular pattern and you see more like follicular architecture maintained, and if you're thinking of Hodgkin's lymphoma, that's NLPHL and not classical Hodgkin's lymphoma. Classical Hodgkin's lymphoma, the typical thing is few neoplastic cells, more background cells, which could be, anything. It could be other lymphocytes, it could be plasma cells, eosinophils, other cells which are present there in the background along with histiocytes. So that is the first, striking when you look in the look under the microscope. That's the striking thing. In nodular sclerosis, the most striking thing is that you have a lot of sclerosis and band formation, and you have fewer neoplastic cells. The rest of the differentiation, what you were talking about, you need to look at whether they are monomorphic, whether they are pleomorphic cells, and then whether they are large cells, whether they are intermediate size cells. All that differentiation helps in non-Hodgkin's lymphoma. And here what we are talking about is NLPHL versus classical Hodgkin's. And in classical Hodgkin's, when you would say a nodular sclerosis pattern. Okay, so you're not thinking in terms of the minute you see it under the microscope, you won't bring a diagnosis of non-Hodgkin's lymphoma, or for that matter, anything. Important point there is anaplastic large cell lymphoma. Again, you have more of sinusoidal infiltration. You have much more neoplastic cells as compared to the classical Hodgkin's lymphoma. So it's different. It's not something similar what you would. So you won't confuse here a classical DLBCL type of non-Hodgkin's lymphoma when you are looking at this kind of morphology. Okay.
Okay. And then, so once this diagnosis has been confirmed, so I would like to do investigation for staging purpose. So in this, I want to do PET-CT for staging.
Yeah, sure. Go ahead. Why you want to do a PET scan? Typical question. Why you would want to do a PET-CT, not a CT? And why PET means PET with non-contrast CT or PET with contrast CT?
PET with non-contrast CT is sufficient, ma'am. So it is preferred over CECT because it has an higher specificity for the both nodal and extranodal disease. And CECT will only benefit if the patient has any significant lymph nodes which is very close to the bowel loops, or any lymph nodes causing compression of the vessels with thrombosis of the vessels. So in this situation, there is an added advantage of the contrast enhanced CT. So otherwise, PET-CT is sufficient for the staging purpose of lymphoma. And there only in case of non-FDG avid lymphomas, the PET-CT can be avoided, like small cell CLL, mycosis, fungoidosis, Waldenström. In these situations, we can avoid even in those cases also. So if you are suspecting any malignant transformation, so for such cases, we can use PET-CT. So otherwise, PCT there is no need. So it is sufficient for PET-CT for staging lymphomas.
A few points. One, when you're using terminologies, make sure that you pay some attention to what you're talking. There's no malignant transformation. Waldenström's and SLL, they themselves are malignancy. What you mean is high-grade transformation, or in terms of CLL, Victor transformation is what you're talking about. Okay.
Yes, yes.
So make sure we use our words carefully.
Okay.
Rightly said, PET-CT is important here because it can upstage and downstage roughly around 6 to 8%, and you can avoid doing a bone marrow because it has a good negative as well as positive predictive value. Therefore, you can avoid doing a bone marrow biopsy in patients where you have a PET-CT for staging and Hodgkin's lymphoma. So that's the reason why you would do. We are not looking at contrast enhanced CT here because it doesn't give you any added advantage. You're not thinking in terms of any surgical resection that you want to figure out whether there is bowel involvement or not, or whether there is any kind of vascular encasement or not. So you're not really looking at that. What you want to see, whether there are lymph node or extranodal sites or marrow involvement, liver involvement, which you want to figure out by doing this imaging, because that will help in staging the disease.
Yes.
So that's for the purpose of doing the PET-CT. So yeah, it helps in upstaging, downstaging, and avoiding the need for bone marrow. Sashwat, can you mute your mic, please? Yeah, we can go ahead with the next.
So I've just taken some pictures of the PET-CT images. It was showing here, the first image was showing the axial section of the neck. It was showing lymph node located in the level 3 region with a significant FDG avidity. So I cannot make out the fat lines clearly, but the vessels are not involved here. And similarly, coming to this side, there is an axillary lymphadenopathy was there, and here the mediastinal lymph, paratracheal lymph nodes are also present. So similarly, there is an paratracheal lymph nodes, and then para-aortic lymph nodes are present. Here they have mentioned there is a significant uptake in the all bone lesions, with the highest uptake has been noted in the right humerus. This is the bone marrow bone uptake was there in this lesion. And so these are the multiple lesions. So imaging findings suggest that patient has multiple sites of disease involving. And one more thing, patient also has an spleen involvement was there. So with multiple FDG avid lesions. and with the size of almost 13 centimeters on the PET scan. So, and then, so based on this, patient is having multiple neck nodes, and then axillary lymph nodes, mediastinal lymph nodes, para-aortic lymph nodes, and then there is an bone marrow involvement with involvement of spleen. So since there is a significant uptake in bone lesion on PET CT, so as ma'am said earlier, I would like to defer bone marrow biopsy in this case, and like to proceed for further with investigations for fitness of chemotherapy and.
No, you're not deferring the marrow involvement because PET scan is showing marrow involvement. Even if it wasn't showing involvement, you won't do a bone marrow examination because it does have significant negative predictive value also. In Hodgkin's lymphoma, when a PET scan shows a diffuse uptake in the marrow, it's always not indicative of bone marrow involvement, more so when you are seeing this kind of neutrophilic leukocytosis, because you have, as a paraneoplastic syndrome, you do get this leukocytosis, which is responsible for diffuse marrow uptake. So it's not the disease involvement per se. But if you have focal involvement, that indicates that it is marrow involvement and not just the paraneoplastic syndrome. So what is the final stage for this patient?
So the stage will be stage 4B, ma'am, with the extranodal involvement, bone marrow as the extranodal involvement.
Anybody? Okay. How would you investigate further and management?
So the further investigations I want to do for fitness for chemotherapy, like renal function test, liver function test, and electrolytes, calcium and phosphorus, PFT, DLCO, ECG, 2D echo. As the patient is 17 years, unmarried, and I just want to do counsel the patient for semen cryopreservation. These are all the investigations for fitness.
Why you want to do calcium phosphorus?
Because the presentation of diffuse lymphadenopathy was there, acute onset, so I just want to load any TLS parameters.
So at baseline answer is yes, but if you're having a Hodgkin's lymphoma which comes with this kind of presentation, even with treatment, the possibility of TLS is very, very low. So it's not something which is mandatory. Okay, what next?
So this is the case history and with the staging with the classical Hodgkin's lymphoma stage 4B nodular sclerosis with extranodal sites of bone marrow with the performance status of 1. So I would like to go ahead management, go ahead with response adapted therapy. So initially,
want to prognosticate?
Yes, ma'am. So IPS score was for this patient, it was 5, ma'am. So IPS score was 5 in this patient because there is an hemoglobin was low. Total count was more than 15,000, and then male, and then patient has an stage 4 disease. So all these factors include under patient having an IPS score of 5, ma'am.
Okay. So what do you think is expected 5-year freedom from treatment?
Will be 62%, ma'am. 5-year PFS survival will
This
be
is based on which data? And on which treatment? Prognostication is only as good as what treatment we are talking about, no?
Yes, ma'am. Yes. This is based on MOP regimen. Treatment.
You're going to give him MOP now?
No, ma'am.
2022?
No, ma'am.
Then?
With the current treatment, the prognostic only interim PET will have a prognostic significance rather than IPS.
No, you would characterize at baseline, and then your things will change depending on what your interim PET is. So that IPS, which has been developed earlier, what is the recent data on IPS in terms of the outcomes, and whether depending on the type of treatment you're using, whether those categories are clubbed together or they remain still distinct in terms of 1, 2, 3, 4, 5.
I'm not sure, ma'am. I will check.
So go back and read that.
Yes. Okay. Yes.
So yeah, what's the treatment which you're planning?
So the response adapted therapy, first I just want to start with treatment of ABVD, 2 cycles of ABVD regimen, and then followed by interim assessment with interim PET.
Okay. So let's say he's PET CR at the end of 2 cycles.
2 cycles, and then I would like to give.
What is that? Sorry.
I would like to omit bleomycin. I want to give only and further chemotherapy with 4 cycles of AVD.
Okay. No, my question was that what would you call as CR at the level of interim PET? What dual score would you call as CR?
Yes, ma'am. In the interim PET analysis, 1 and 2 we will call it as an CR, ma'am. But 3 we will take it as an not 3 is not included in CR.
Okay.
Whereas in the end of treatment scan, 3 1, 2, 3 will be included in the CR.
Does anyone differ here or everyone agrees? Okay. Any other alternative regimen?
Yes, upfront, ma'am, or after assessment, we can.
No, before now. So if you said that he is in CMR, then in that case you are changing to AVD. That's fine. Upfront, do you want any other
escalated BCOP we can try, ma'am. So similarly, after giving 2 cycles of escalated BCOP, and then we can do response assessment. If PET is negative, and then we can de-escalate to AVD, ma'am. 4 cycles of.
Okay. Any other alternative you have there?
If
Hello.
Ma'am, yes, ma'am.
Any other alternative? One is you said de-escalating to AVD. Any other alternative? And even in the frontline treatment, do you have any other alternative?
Or standard BCOP instead of escalated dose of BCOP.
Anyone else?
Ravi, any regimen using some novel agents that you are heard of?
Maybe along with that, instead of bleomycin, we can use brentuximab vedotin, ABVD.
Hello.
Sir, yes, sir.
Yeah. So, so what is the evidence for that, Ravi? Using novel agents upfront?
Echelon 1 study, sir.
Okay. So, what was the results of Echelon 1?
It has shown similar between both brentuximab versus bleomycin. Even if you do both.
Similar what?
The PFS, no PFS, there is no overall survival benefit was there.
Yeah, so there is improvement in the progression or event-free survival, but there was no improvement in the overall survival, right?
Yes, sir.
Okay, so this is one of the alternative. Even in situations where the patients where you don't want to use bleomycin because of any contraindications, then you have an option of using brentuximab as opposed to bleomycin. Okay, so madam has asked that after 2 cycles the PET is CR. You said you will bring down to AVD or AVVD. Any other option after 2 cycles of BCOP? Yeah, so you can continue 2 more escalated
BCOP,
okay.
And then we can do a PET CT. If the PET came out as negative after 4 cycles of escalated BCOP, and then we can give 2 more cycles of escalated BCOP, completing total 6 cycles of regimen.
Okay. Okay, so so this French study, this French group has done the study on advanced Hodgkin, and this approach that you were telling, that starting with an escalated backup and bringing down or de-escalating to ABVD, is the approach usually practiced in um, French people. And that study, what they have done is that those who are negative, they have brought down to 2 more cycles. So total 4 cycles of escalated backup, and that is enough. Okay, in advanced Hodgkin. So you said about standard backup. Standard backup is not now recommended. It has already been proven that escalated backup is superior to standard backup. So never say that standard backup is also an option. Okay.
Yes.
So if in this situation, if you have to give an answer, one is ABBD based approach and then escalating after 2 cycles. The other approach is starting with an escalated backup, and third approach is using a novel agent based treatment using brentuximab. Okay, so these are the 3 approaches.
So just to ask one more thing, Ravi, you said brentuximab. What
Yes,
was the inclusion criteria for brentuximab trial? So did they include people who were below 18 years?
Not sure.
So they included patients 18 and above. So stringently speaking, the data is not applicable to this particular age group. Okay. So you're talking of 18 and above, answer is yes. And as Lingraj said that, there was improvement in modified PFS, no difference in OS.
Okay.
And the special subgroup which benefited most was this, what you're talking about, IPS 5 and above. They did, after the criticism of modified PFS, they looked at PFS also, and that was also better. But yeah, these are all secondary analysis is what you would, take as, not really confirmatory.
Okay.
And your other suggestion that you will do to escalated backup PET CT, if somebody is in CMR, as Lingraj said, you will give only 2 cycles and then you will stop. You won't continue 6. And once you have CMR, I don't see there is any point of repeating a PET scan. As you suggested that we'll do 2 more and then we'll repeat a PET, and if PET is in CMR, we'll give 2 more. Okay, so there is no point repeating, because the whole idea of doing an interim PET CT after 2 cycles, because that's prognostic as well as you can take your therapy. That's what your response adapted therapy is, and you're taking your therapy decisions based on that. So you'll just give 2 more and then you will stop.
Okay.
Okay. So that's about it. Do we have a short case also?
Yes, ma'am.
So then maybe we can move on, because I think it's already 9:23.
Okay, thank you.
Am I audible?
Yes, Abhishek, you are audible.
Yes. So, good morning all. I am presenting a short case. A male, 42-year-old Hindu, is a resident of Uttar Pradesh. He presented with our OPD with the chief complaint of the swelling both sides of neck since 2 months and intermittent fever since 1 month. So patient was apparently healthy 2 months back when he noticed the neck swelling, which is incidentally noticed grape size and the onset in the both side of upper side of neck since 2 months, which is incidence in onset, gradually progressive in size. Swelling not associated with any pain, redness, ulceration, discharge, any dysphagia, throat pain, change in voice, breathlessness, redness, ulceration over the skin. He also complained of the fever, which is low grade intermittent that gradually starts since last 2 months and relieved by when he takes paracetamol. Fever is not associated with any chills or rigors. So no significant any past history. He is denied for any addiction, no family history of malignancy, no history of TB and contact with the TB in past, no history of any recurrent infection in recent, no history of any alternate form of medicines. So my impression for this patient is 42-year-old male, is presented with the 2-month history of progressive bilateral neck swelling with intermittent fever. So my differentials on the basis of the symptomatology.
So Abhishek, your slide is not moving. I think you have to stop there and reshare. But anyway, you just quickly go to the summary slide. Okay,
Yes,
your
sir.
slide is not moving.
Right.
Go to the summary slide quickly.
Yes, sir.
Yes.
Yes, sir. So is a 42-year male, is a 2-month history of progressive bilateral neck swelling with intermittent fever. So my on the basis of the symptomatology, my differentials is the lymphoma because of the bilateral swelling with the fever from last month, and also in view of prevalence in country. So we can say is a tuberculosis, or on the basis of the symptomatology is my second differential.
So Abhishek, no, when you say intermittent fever, no, that is very vague. Very vague. So you just have to be little explicit about what do you mean by that. So when you say that fever, whether it was high grade, with chills or rigor, intermittent fever, like how many days in last 2 months, So you just have to be little more explicit when you say that in the exam. Even in a short case also, when you summarize, you just have to be little more elaborative there.
Yes,
okay?
He has a low-grade fever, which is intermittent, and it started in initial patient had a complaint of fever in night time, but right now in last 1 week he is also in daytime also, and it not had any chills or rigors.
Okay, I think no. So this short summary is not that complete. You just have first is you have to describe the history in short, and also what intervention has been done. So you can just say that no cancer-directed treatment or investigation has been done, and the patient directly presented to us. Okay, so these are my differentials. Okay, fine. So what did we do for this patient? So on lymphoma, you want to be specific here, or you're just happy with just saying a broader diagnosis of lymphoma?
With a short history, I can go with the high-grade lymphoma.
Yeah, you can just say that non-Hodgkin's lymphoma.
Yes,
right?
sir, non-Hodgkin lymphoma.
So with this 2-month history, no, very unusual, no. So we can just say that it is most likely non-Hodgkin's lymphoma.
Yes, sir.
Okay. Yes.
Yeah. So move on to my examination part. Performance status ECOG is one. And
again, summary. Please summarize any positive findings and then completely, summarize the findings quickly.
Yes, so here's my summary for after examination is a 42-year male with a 2-month history of bilateral progressive neck swelling upper neck with intermittent low-grade fever, and on examination patient has a bilateral non-tender hard fixed cervical lymph node on a bilateral level. Second, on oral examination patient also had right side
hard fixed is not very common in lymphoma, so you should be careful when you use the word.
Yes, sir.
Hard and fixed is something which I think in terms of solid tumor node.
Yes, sir.
Okay. So lymphoma nodes are mostly firm and they're mobile. Okay.
Yes, sir. So it's a non-tender hard and fixed to the underlying muscle, and we cannot lift the skin over the lymph node, sir. And on my oral examination, patient has a right side tonsil enlargement, which is right shiny surface, grade 2 and tonsillar enlargement. No any other palpable lymph nodes. So this is my summary with the patient. Patient with the bilateral neck swelling and tonsillar enlargement with low-grade intermittent fever from last 2 months. So my differential for this patient is high-grade non-Hodgkin lymphoma in view of short summary, history of 2 months. My first with the DLBCL as the incidence of DLBCL, and second is the ALCL, and third second is my carcinoma tonsil as a differential, because patient has tonsillar growth as well as bilateral neck swelling, which is hard.
Okay. So I think for the histology, we should not speak about the histology now. You can just say that it's a non-Hodgkin's lymphoma. You can discuss with the histology when the biopsy report comes. Okay. Yes. So why did you say carcinoma tonsil?
So tonsil growth with neck swelling.
Okay. So what was the finding of the tonsil examination?
So tonsil is a tonsil is an enlargement which is red and shiny surface tonsillar enlargement.
So is it unilateral or bilateral?
It's a unilateral, right side only, sir.
Okay, fine. So that is a possibility.
Yes,
yeah,
sir.
yeah. So if it is a bilateral tonsil enlargement, typically follicular growth is typically seen in lymphomas. If it is an unilateral growth, carcinoma is a possibility. Yeah,
Yes. Yes.
agreed. So then what did we do? Investigations.
So we do, sir, blood investigations, complete blood counts, and kidney function tests, liver function tests. So I had a investigation for of this patient. So patient had the hemoglobin 7.4, the TLC 6.5, and platelet is 3.87 lakh. And patient MCV is low, MCH is low, and RDW is normal. And my differential count is neutrophil 70 and lymphocyte is 17%. LDS 416. And other uric acid is 7.1, urea 30, and it is 0.9. So other parameter is within normal limits.
So you can go to the histopathology
Yes.
slide.
Yes,
Yeah.
sir.
What was the biopsy report?
Yes, sir. So this is the
No, I can't see that. Can you just move? The slide is not moving.
okay, sir.
Yes.
Yes. So this is a histopathology, the biopsy taken from the tonsil, and it showing the stratified squamous epithelium with atypical lymphoid proliferation with the large cells with a nodular pattern and focal diffuse pattern. The nodules are rich in large size cell with interspersed centrocytes, and focally seeds of large size also seen. On the ISC, the cells are positive for CD20, CD10, and BCL6, and negative for CD3 and CD23. And MIB proliferative index is 16%. So on a morphological and histochemistry, it's a non-Hodgkin lymphoma, diffuse large B cell type.
Okay. So if I have to just say that, how do you see a histopathology or morphology of a diffuse large B cell lymphoma? How will you describe that?
Yes, so
this is a this is a tonsil, but if you have to give you a lymph node biopsy,
yes, sir.
And how will you describe that? How it will look like on a morphology?
Yes, sir. On a morphology, DLB on morphology, it's a prominent nuclei with a basophilic cytoplasm and
No,
large cells.
so wait. So the thing is, so whenever you describe that, no, you have to describe in a very simple term, like that there will be loss of lymph node architecture and a diffuse seat of monotonous population of cells, right?
Yes.
Unlike the biopsy that Ravi has described in his previous case, where you have seen large cells with lot of inflammatory milieu,
Yes.
right? So this is like this will be looking like a seeds of large cells, and then and all the cells are looking the monotonous population, like the cell size will be similar.
Yes.
And so that is one morphological description of diffuse large B cell lymph. So that is one way to say that it is diffuse large. Then there is this classification of cell size will come that Ravi has described, that cell size, medium, large, or small, and based on that you have again differentials.
Yes.
Understood?
Yes, sir.
So two things you have to say, that about lymph node architecture and diffuse seat of monotonous population of cell. So in this biopsy report, can you say that which group it belongs, whether it is germinal center type or non-germinal center type?
Yes, sir. It's a cell is CD10 positive, so we can say it's a germinal center type.
Yeah. So CD10 and BCL6 both are germinal center markers.
Yes, sir.
So then it will be a GCB type of diffuse large B cell lymphoma. Okay.
Yes, sir.
Okay. Yeah. So that's from my side. Anybody, madam, you want to add anything? Sir?
Nothing from my side.
Okay, so move ahead, Abhishek. So what was the stage and how you want to treat this patient?
Yes, sir. So final diagnosis of this patient is DLBCL stage 4 with extranodal side of stomach, and with the IPI score is 2/5. So we could plan for this patient is a 6-cycle R-CHOP, and with the interim response PET scan after 4 cycles, and residual and offer to the ISRT to the residual sites.
Okay. Okay.
Yes.
I think that's okay for this. We have to move to the next case. Anybody has any doubts, they can ask. Otherwise, you can move to the next, the last one, that is lab interpretation. Right. Has anybody has any questions? Residents, they can unmute and ask. Okay, I think you can stop share, and Laboni can share our screen. Can you make it full screen? Yes, yours is lab interpretation, right?
Yes, sir.
Yeah. So be quick on the history and then go directly to the lab.
So this patient is a 50-year-old male with no comorbidities presented with.
Is it possible to make it full screen, because you will have some images? And
I am not. These slides are not mine, ma'am. I was told to. I was told I would have to interpret. I am not sure.
No, that's fine. Whosoever is doing it, projecting these slides, make full screen, because there are going to be some images. It will be difficult for some people to see it on this kind of a presentation without a slideshow mode. So that's what I'm requesting.
I'm doing that now. It's in slideshow.
Yes. So this is a 50-year-old male with no comorbidities presented with a weight loss of 3 kg in 6 months, on and off fever. He noticed small nodes in the neck in 6 months with heaviness over the left side of abdomen since 2 months. On examination, he had neck nodes positive, largest 2 into 2 centimeter, axillary lymph nodes, largest 2 into 2 centimeter, and palpable splenomegaly 11 centimeter from the left costal margin. So hemoglobin was 11.9, TLC was 59,000, platelets were 1.5 lakhs. MDC showed 14% neutrophils and 86% atypical lymphocytes. So the peripheral smear is showing lymphocytes with a thin rim of cytoplasm, dense nuclei, and there is evidence of architectural distortion, so probably smudge cells. So and with the diagnosis of, and with the presence of leukocytosis and with lymphocytosis also, I would one possibility. I would consider, and given the history, I would keep a possibility of CLL in this condition. Other possibilities could be viral infections such as infectious mononucleosis or.
Abuni, what's the size of spleen?
11 centimeters.
Okay. Which infectious mononucleosis is to the spleen size of 11 centimeter?
Yes, ma'am. That is
okay. And where would you see this kind of a lymphocytosis there with 59,000 TLC and with 86% being lymphocytes? And is this the appearance of infectious mononucleosis lymphocytes, what you see?
No, ma'am. This is most likely CLL.
Why not follicular lymphoma? Why not splenic marginal zone lymphoma?
These they would also present with lymphocytosis. However, usually the lymphocytosis may not be this profound, TLC of 59,000 or.
The peripheral smear in front of you, no?
Yes, ma'am. That is also.
So that is, you're not given just the history and the WBC and examination, no? You have given a peripheral smear also.
Yes, ma'am.
Correct. So tell me, in the peripheral smear, what are the features which are pointing against follicular lymphoma or splenic marginal zone lymphoma for that matter?
So in follicular cell lymphoma, there would be cleaved lymphocytes, and they would usually be larger in size. And for marginal zone lymphoma, typically they would have some these cytoplasmic projections like villus projections, and And typically, in marginal zone lymphomas, they usually have anemia, more significant anemia and thrombocytopenia.
Is it always the case that they have more significant anemia and thrombocytopenia?
Typically, it is associated with anemia and thrombocytopenia in marginal zone. Sorry.
That's always the case. So if you don't have that, you can't. So you can't have peripheral blood showing abnormal lymphocytes without anemia and thrombocytopenia.
No, ma'am. That's.
What is this large cell which you're seeing? Most of the other cells are uniform small lymphocytes with predominant nucleus, where you're not seeing nuclei with a thin rim of cytoplasm, whereas there is another larger cell which is almost double the size of the other lymphocytes.
That is a smudge cell.
Smudge cell. On the left-hand side, on the top, there are two cells. One is small, one is larger. What is that larger cell?
Okay, that one is a monocyte.
I strongly recommend that we all go to the lab and please try and identify first the normal cells. And this is going to be a typical exam case. Yeah. So definitely look at peripheral smear of a CLL or SMZL and follicular lymphoma and hairy cell leukemia. Other than the acute leukemias, in CLPDs, definitely look at these 3 or 4 peripheral smear, but more important than that, identify the normal cells first before we start commenting on the peripheral smear. Okay, so all of you.
I'll move ahead, ma'am.
Lingraj has asked if there is anyone else who wants to comment on that large cell.
Any final year? What do you see in a CLL?
Okay, I think Lingraj is not audible. You can move to the next slide, Akhil.
So this is a flow cytometry report. So this is showing CD5, CD19, and CD23 positive. CD79B is positive but low, and CD10 is negative. So in view of CD5 and CD23 being and CD19 being positive, we would keep this is consistent with CLL.
What other parameters are here which are consistent with CLL? One is 523 dual positive on the same population, which are B cells as indicated by CD19 presence. What other parameters here indicate that CLL?
CD79B is typically low in CLL as compared to other B cell, other B cell markers. And
what else? What about FMC7?
That's I'm not sure.
Okay. What is Matute score on flow cytometry? Okay, sure, you go and read that. So today's exercise is going to be looking at Matthews score, looking at what immunophenotypic markers. There is a clear table for when you are evaluating CLPD, so BCLPD. So you basically look at what, whether first it's B cell or not, and then you have CD5, CD5 positive or negative. And then based on that, there is subsequent algorithm to say whether it's CLL, whether it's PLL, whether we are talking in terms of follicular lymphoma, whether you're talking of mantle, whether you're talking of SMZ. So all that, that is very clear. There are algorithm. There are some gray zones, but a picture like this doesn't indicate any gray zone here. Okay. So make sure you read that algorithm, read what Matthews score is, and definitely look at the peripheral smear. Yeah.
Yep.
Okay.
So this is the cytogenetics panel. In this case, this case is positive for IGH deletion. Generally, so basically, IGH is immunoglobulin heavy chain variable mutation. So typically, it is associated with a better prognosis, and it is associated with
what are you looking at? You're looking at FISH report, right?
Okay, sorry. So this is positive for, so it is negative for ATM, TP53, monosomy 13, and trisomy 12. So usually the most important factors in decision making for CLL would be presence of TP53 mutation and presence of IGHV mutation. So in this case, TP53 is negative. So
so other than IGHV and TP53, there is nothing else which has prognostic implication?
Yes, ma'am. So 13q deletion would have a good prognosis. ATM deletion is generally seen in younger patients. And
13q is better than not having any cytogenetic abnormality? So my question is, if you were to rate prognostication based on the cytogenetic abnormality, can you list it? Starting from the better to worst.
Best would be 13q deletion. The best would be no cytogenetic abnormality, then followed by 13q deletion. Then trisomy 12 is, I mean, there is not much data, but generally it is considered intermediate in intermediate prognostic significance.
Not much data meaning?
In the sense that
where are we testing? Why have we decided the FISH panel based on why to include one additional marker? It costs, the probe cost, it requires effort from the lab. So why have we included that?
So
anyone else want to rate the cytogenetics and the prognosis starting from best to worst?
So ma'am, can I just can I attempt?
Yeah, please.
Yeah. Actually, trisomy 12 is typically associated with the Notch 1 mutation, and so they generally have. I mean, so they have an intermediate prognostic significance, followed by ATM deletion, which is typically seen in younger patients, and with they have bulky lymph nodes and an aggressive course. And the worst prognosis is seen in TP53 mutations.
Are you seeing a mutation on cytogenetics or FISH?
This is on just deletions.
Sorry?
No, this is just a cytogenetic.
Yeah. So do you see mutation there? What do you call that when you look at cytogenetics and you're talking in terms of 17p?
17p deletions.
Correct. So you're not seeing mutation there, right?
Yes, ma'am.
Okay. Okay. So what's the relevance of this IGH translocation here? And what is the prognostic relevance of complex karyotype, and when do you call it as a complex karyotype in CLL?
So, ma'am, complex karyotype is when there are 3 or more cytogenetics abnormalities, and this has a poor prognosis.
Poorer than 17p deletion?
Yes, poorer than between the two. I'm not sure, ma'am, but it has a poor.
Okay. Can we move ahead to the last slide, Akhil?
So here we see that this is the NGS report, and here it says that the IGHV mutation status is that it is mutated. So,
and why do they call it as mutated?
In this they had. So normally, IGHV mutation is when there is a mutation from germline of more than 2%. So that is the definition. And here, according to this, so they have taken, so they've mentioned also that following the 98% cutoff,
They've written, no? The rearranged IGHV has 89.5% nucleotide identity with the germline sequence. So that's the reason why they have called mutated. Okay. Implications of mutated versus unmutated.
So a mutated will IGHV mutation is a good it is a good prognostic factor typically, and the cytotoxic chemotherapy regimen FCR was also used typically in patients with IGVH mutations, and is recommended.
Was it used, or
it has
they found that once you use FCR, those who have mutations, they do better?
That subset did better.
Okay. And is there a difference in terms of cell of origin of IGHV mutated CLL versus non-IGHV or unmutated CLL?
The IGHV mutated cell is typically more matured, while the IGHV unmutated is it's germinal center naive cell. So it has a more aggressive course.
Okay. Any other implication currently you would have if you are having a patient who requires therapy and it has mutated versus unmutated? Any differences in terms of how you would counsel? What treatment would you use?
Ma'am, for IGVH?
Yeah. Labuni, are you answering? Because I'm not able to hear.
I'm not sure of any other point.
Okay. Okay. Anyone else? So the last question is, what other parameters would you want to consider before starting therapy?
So, ma'am, we would like to check the TP53 mutation status also, and we have to assess the fitness of the patient. So, if TP53 mutation is present, the patients are typically not sensitive to chemotherapy, and other targeted therapies are.
But would you assess first that this patient requires therapy?
Yes, ma'am. Yes, ma'am.
So how would you assess that?
So first, so there are some criteria for assessing whether a patient requires a therapy. So if a patient is, so the patient would have to have massive nodal enlargement of more than 10 centimeters, massive spleen enlargement of more than 6 centimeters below the costal margin, progressive worsening anemia or thrombocytopenia, typically less than 10 hemoglobin and less than 1 lakh platelet count, lymphocytosis which is worsening. The doubling time of the absolute lymphocyte count is checked. If that is less than 6 months, then that is an indication for therapy. Autoimmune anemia or thrombocytopenia that is not responding to steroids, and any other disease-related like debilitating symptoms such as significant fatigue, fever for more than fever or night sweats lasting for more than 1 month, or a weight loss of more than 10% within the last 6 months.
Okay, or the organ dysfunction.
That's not organ dysfunction.
Okay. So then, let's say that this patient has he had splenomegaly and for which he is symptomatic. So how would you plan treatment for him? You know the age, you know the other parameters which you wanted to know. How would you plan treatment?
So first line treatment, if the patient, considering that this patient is, assuming that he's negative for the deletion 17p, it would depend upon his fitness. So if the patient is fit, we would like to consider an aggressive regimen such as FCR or ibrutinib. If the patient is more than 65 years, we can give a BR regimen. And if the patient's fitness, if the patient is not as fit, then unlikely to tolerate toxic therapies, then we can consider BCL2 inhibitors, venetoclax plus obinutuzumab, or ibrutinib.
I'm going to interrupt here. You need to go back and look at the treatment recommendations, what you're suggesting. Yeah. Especially if you're talking in terms of unfit patient, the kind of therapy which you have recommended, go back and look at the recommendations. Recommendation based on the age, performance status, organ function, where you decide the tolerance to treatment, then disease-related parameters, which basically include the cytogenetic, the predictive markers for therapy, including the IGHV mutation status. So go back and read that. Yeah.